Hello, I'm Dr. Lowe. This is a brief overview of some abnormalities of the GI tract. It's a corollary to the embryology materials in the foundation section. The entities that we will at least mention include tracheoesophageal fistula, esophageal atresia, ectopia or heterotopia, pyloric stenosis, Meckel's diverticulum, and Hirschsprung's disease. Tracheoesophageal fistula and esophageal atresia were already covered in the vital fluids and gases block, so this is just a brief reminder. These represent abnormal segmentation of the foregut, either too much or too little separation. Too much if there's an atresia, too little if there's a fistula. The pathophysiology differs with the anatomy, and there are a variety of anatomic variants. However, all of these result in surgical emergencies in the neonatal period because fluid, that is milk, doesn't get into the stomach or only partially gets into the stomach, and some variable portion gets into the trachea, where it is not a good thing to have. The complications of this are that most babies who have a tracheoesophageal fistula or esophageal atresia have other congenital malformations, which vary from making treatment more complicated to making it impossible. Inlet patch or pancreatic rest are heterotopias where tissue occurs outside its normal location. This can be gastric mucosa in the proximal esophagus or small nodules of pancreatic tissue in various other places in the wall of the stomach or small intestine. This is really not surprising if you think about how complex the embryology of the pancreas is. Pyloric stenosis is actually an acquired abnormality in the neonatal period. It's hypertrophy of the pyloric smooth muscle. Because of this, which we'll show in the next slide, the formula doesn't get from the stomach into the small intestine. The baby will start vomiting. The hypertrophied muscle actually can cause a mass that's palpable on abdominal exam if the baby is quiet. It's more common in boys than girls. Treatment is surgical with incision of the involved muscle. It doesn't have to be resected, just incised. There's also a pseudo-physical sign that sometimes can be seen, and that is erythema of the skin of the anterior abdominal wall. This is a pseudo sign because it's a result of every medical student and resident in the department lining up to try to feel the mass. Here's a diagram of the pylorus, and you can see here the hypertrophied muscle. Meckel's diverticulum is a true diverticulum. It results from incomplete obliteration of the vitelline or omphalomesenteric duct. Actually, I think the omphalomesenteric terminology, even though it's a longer word, is better because at least that tells you where it's coming and going. It's not uncommon. About 2% of people have one of these. But of those who have them, only about 2% have symptoms. In a quarter of the cases, there is heterotopic gastric or pancreatic tissue in the diverticulum. The heterotopic gastric tissue can produce acid and peptic ulcers adjacent to the diverticulum, which is one of the ways this can present. Here you can see the diverticulum. And let's see if I can get that pointer up here. For some reason, I can't get it. Oops, let's go back. There it is over here. There are several things. It's about usually within 2 feet of the ileocecal valve, and they're about 2 inches long. But you can see this diverticulum over here. Hirschsprung's disease is another abnormality. This is an abnormality in neural. The aganglionic segment here then is the narrowed segment, and that has hypertrophied nerves but no ganglion cells. the ganglionated segment up here is dilated and has hypertrophied smooth muscle but normal ganglion cells. Treatment is resection of the ganglionated or aganglionic segment down here, and what surgeons can now do is actually pull through the ganglionated bowel because the anal sphincter still works or has the potential of working, so that these children do have the possibility of having adequate fecal continence as they grow up. To summarize, these abnormalities can be classified, in addition to being classified anatomically, they can be classified developmentally. Some are abnormal closures of tubes, such as tracheoesophageal fistula and esophageal atresia, or Meckel's diverticulum. Others represent abnormalities of cell migration, such as Hirschsprung's. The heterotopias are abnormal differentiation, and pyloric stenosis is actually an abnormal proliferative response. The effects of these abnormalities vary, and they can produce a variety of GI symptoms. Obviously, atresias and stenosis, as well as the lack of peristalsis in Hirschsprung's, produce obstruction at various levels of the GI tract. Abnormal communications between tubular structures can also occur, as in tracheoesophageal fistula, with aspiration and/or vomiting. Occasionally, there can be effects of the abnormal location of cell products, for instance, the relatively rare ulcers near Meckel's diverticulum. I hope this has been helpful. Thank you.